Sorry, recording. So today we'll do a couple of things. So our first topic of the day is lymphadenopathy, malignant and malignant lymphomas. So from your basic understanding of like medicine so far, can someone like just tell us what lymphadenopathy is? That's a simple definition. But Thomas, can I unmute and like give me what you think lymphadenopathy is? Or Brenda and Mark. Oh, better than you did. Yeah. Yes. Let's go on.
Lymphadenopathy is a condition whereby abnormal lymph nodes. That's what I know.
Okay, so we'll see. So yeah, lymphadenopathy basically is enlargement of the lymph nodes or swelling of the lymph nodes by simple terms. So what's the mechanism? So it usually presents as a manifestation of systemic illness, and it can be accompanied by symptoms that you've been hearing all along. So we'll go straight into the etiology, and the cause is like what should be going through your head when you find a patient with lymphadenopathy to like find out the etiology basically. So most common cause of lymphadenopathy in our system at least is the viral. So like viral etiology is the most common. So this is usually characterized by mild transient lymphadenopathy lasting less than 6 weeks. So some of the viruses that can cause this, as I've listed them here, is EBV, HSV, CMV, hepatitis B and C, and the most important one now we want to talk about is HIV. So you know HIV causes persistent generalized lymphadenopathy. And you guys did a session on HIV a few weeks ago, I think around 2 weeks ago. So what WHO stage is characterized by persistent lymphadenopathy in HIV? Because you know, like this is how you are able like to stage these people. When you find a patient telling you they have this kind of lymphadenopathy for this long, you know, like whatever stage they're in. So yeah, Victoria in the chat has told us stage 1. That's exactly what it is. Stage 1 HIV, WHO classification. So lymphadenopathy could be from the HIV itself or from HIV-related infections. So what are some of the HIV-related infections that you guys have come across? Yeah, so like, just for the sake of time, I can just go through them quickly because we have a lot to cover. So some of these things are TB, obviously, histoplasmosis, CMV infections, as we said before, Kaposi sarcoma, lymphomas, and dermatological conditions, you know, things such as seborrheic dermatitis. Those are many related infections that come with this lymphadenopathy. So the next common etiology is bacterial, and the most important one here in our case is TB. So TB causes a type of lymphadenopathy called TB adenitis or scrofula simply. So TB is of significance in 2 ways. So in seronegative and seropositive patients, because you know TB is one of the many things in HIV, yeah? One of the differential whatever, one of the common like manifestations, yeah. So in seronegative, what type of lymphadenopathy do you expect? So in a normal non-HIV person, expect unilateral cervical lymphadenopathy with no discharge in sinuses. So let's find them on one side, mostly the cervical region. And as you'll see, a lot of lymphadenopathy usually occurs in the neck region, the cervical region, going down. So in the cervical, then you go to axilla, all that, because simply the bare fact that disease usually like starts like there's a lot of openings in your nose and your mouth and all that. So like those lymph nodes are like easily accessible by those pathogens. So that's what you expect in seronegative. So positive, they'll be diffuse. So diffuse meaning not like it's multiple places, bilateral, right? So it's diffuse and bilateral lymphadenopathy, indicative of disseminated disease. Because in seropositive, you know, like you expect, you know, TB to be disseminated, like extrapulmonary TB, all all those things. Yeah. So another cause of bacterial lymphadenopathy is this is due to strep and staphylococcus. So it causes localized lymphadenopathy or local adenitis. This is usually severe and acute. So when you're taking the history and you find that this patient will tell you they are okay like a few days, then the next day they experience extremely painful lymphadenopathy, especially in the neck region. That could like lean you towards staph and strep, localized lymphadenopathy. Again, you'll see how like to differentiate between bacterial and non-bacterial, how to manage the lymph nodes in just a few slides. Next. Next etiology is neoplastic, which will be discussed in a few. And lastly is fungal and parasitic. So toxoplasmosis, histoplasmosis. There's not much to say now. So how do you go about evaluation of these things? So you go collect the patient, they tell you that had swellings, or during examination, you find this particular swelling they're talking about, the lymphadenopathy. So what are the 7 things, or how many are these? 1, 2, 7 things that you need to bring out in your history. Yeah. So one is the location. Obviously, you always start at the location, right? Is it in the axilla, or is it in the cervical region, inguinal, epitrochlear, supraclavicular, all those areas? Basically, location, yeah? And if it's bilateral, you say bilateral. If it's not, you say unilateral. Next is the size. So size is, how do you go about the size? So axillary and cervical lymph nodes are usually less than 1 centimeter. So if you find the lymph node is like 0.8, 0.7 centimeters, that's insignificant. Those are normal, yeah? Inguinal lymph nodes, along the inguinal canal, are usually about 1.5, less than 1.5 centimeters. So you guys know how to measure your finger. So your finger is 2 centimeters, and you put your finger over there. Yeah, next is epitrochlear lymph nodes. So where are epitrochlear lymph nodes located? So from your first year or two, you're still in touch with that. Remember, in the elbow, in the medial aspect, there's a trochlear notch. So just above the trochlear notch, or the medial epicondyle of the humerus. That's where you find the epitrochlear lymph nodes. Yeah. So trochlear lymph nodes significant are usually like the swelling is significant. It's greater than 0.5 centimeters. So odds of malignancy increase, obviously, with size past 2 centimeters in all of these things. So 2 centimeters, if you see like your anemies are 3-4 centimeters, that's obviously that's going towards the territory of malignancy. Because you should always square it out. Consistency. So what's consistency? Are they soft or are they hard? So soft are usually indicative of inflammatory. So your TB are there, your localized lymphadenopathy, the strep and stuff are there. Then are they hard or rubbery? So these are usually common in malignancy, hematological malignancy, lymphomas, and all that, as you see in a few. So fixation, are they fixed to the wall behind them? Yeah, if they are mobile, these are usually inflammatory lymphadenopathy. They're usually of inflammatory origin. If they are fixed to the wall, they are neoplastic. Next is discrete or matted. So what does discrete or matted mean? Discrete means it's one, like it's solitary. You can like feel the edge around, you can say this is one. But matted means it's like 5 lymph nodes, they've attached to each other. They're grouped together. They're like one big thing, but it's like a combination of these things. So discrete usually points towards inflammatory. Okay, this is not very, it's kind of neither here nor there, but matted usually points towards malignancy. So anytime you see matted, discrete or matted could point towards malignancy, but then matted always points towards malignancy, especially Hodgkin's lymphoma. Next characteristic that you're supposed to bring out is the tenderness. So are they tender or are they non-tender? So tender and inflammatory, as just said before, in localized lymphadenopathy, that you expect in staph and strep. Yeah, you find this thing as severe and it's acute. So severe meaning it's very painful. Yeah, they are tender. The knees are usually tender. Inflammatory. So even in TB, adenitis or scrophula, as you just call it, you expect them to be painful. In non-tender, in neoplastic etiology, they won't be tender. They just be rubbery and they'll be fixed, rubbery, matted, and non-tender. I feel like that's the best way to go about it. Yeah, how you'll find inflammatory, usually soft. They are mobile. They may be discrete or matted, and they are tender. In neoplastic, they are hard or rubbery, fixed to the posterior wall, and matted and non-tender. So they're not painful, yeah? Then the surface. So when you whatever on the surface, do they feel smooth to touch or are they irregular? Yeah? Does it feel like they can nodule a surface, sort of, yeah? So smooth, inflammatory, irregular, neoplastic. So these things should like come about in your history or in your examination. Once again, I feel like another thing you shouldn't like go too much into history, because things such as discrete, you can't ask a patient if it's discrete. So you bring that out in your history, it looks very off because about things that you ask a patient. So what do you ask in the history? That's something that's supposed to come out in your history, some in the examination. So location, obviously this can come out in the history. So you can ask the patient, yeah, was it here or there? So this is the history. So the size is in the examination. The patient can't tell you what 1 centimeter is. So size is examination. Consistency could be in the history, could be in the exam. You can put it in either. That's easy. Someone knows what's soft, what's hard, yeah. Mobility, examination. Discrete or matted, examination. Turn down and tender, history. Obviously, the patient can tell you if it's painful or not, yeah. Surface, examination. So these are some things to bring in history and exam. Just be a good judge of you know what makes sense in the history and what makes sense in the exam. So yeah. So next slide. Okay, so that's it for lymphadenopathy. This is what to say. So it's a swellings, and this is how you go about the swelling. Yeah. Next is now the second part of the first slide. Yeah, malignant lymphomas. So lymphomas could be either benign or malignant, right? But the meat of our discussion here today is malignant lymphomas, right? So what are malignant lymphomas? These are solid malignancies of the lymphoid series. So what are the lymphoid organs or lymphoid tissue that you should know by now, like you come across? So there's primary lymphoid tissue and there's secondary lymphoid tissue. So primary lymphoid tissues is basically where maturation of precursor cells occur. So the blasts. So what are some of the examples of primary lymphoid tissues? Now, I just need two people, or like one person can just unmute and tell us two examples, or like the two main examples of primary lymphoid tissue. Okay, let me see. So is just in the chat, in the whatever, can you just unmute and tell us two primary lymphoid tissues? But just from the definition, where do maturation of precursor cells occur? Just feel like what's the best way to put it. Okay, so thank you for the guys answering in the chat. The bone marrow and the thymus, that's what I'm looking for, yeah? So the bone marrow and thymus are primary lymphoid tissue. Secondary, you guys in the chat can just continue answering. What are the secondary lymphoid whatever? These are like there's a couple of these. Lymph nodes, spleen, yeah, okay, yeah, that's on the right track. So some of the secondary, meaning you have lymph nodes, you have the spleen, and you have do you guys remember MALT? Mucosal associated lymphoid tissue in the intestine. So there are some of the secondary lymphoid tissue that are there. So with that knowledge in mind, yeah, with that knowledge, you now understand like what abnormality in these organs can tell you what cells are being abnormally produced. So yeah, we'll see that in a few. Next, there's this picture. I know there's another very grotesque image that a lot of people don't like of hematopoiesis, the one with the arrows and all those things. But there's a simplified version of this that I feel like if you have your phone, you can just take a photo or like screenshot. But this is basically all you're talking about in leukemias and lymphomas. But for now, we just cover lymphomas because that's what we're doing now. So if you have the hematopoietic stem cell here, yeah, gives rise to the lymphoid and the myeloid progenitor. Myeloid gives the blood cells, and then lymphoid is now the lymphatic system, right? So in the lymphoid progenitor cells, you have B cells and T lymphocytes. B cells, you need the spleen, T lymphocytes, the thymus, T for thymus, So this is where like lymphomas occur, So in lymphomas, you have abnormalities in the B cells and the T cells. That's why if you, for those guys who are in, actually, no, I'll say that later. But yeah, so this is the focus of our anemia today. If you have this image in your head, you just know what happened to these things, So if there's lymphomas and then there's multiple myeloma, which is an plasma cell, whatever, neoplasm, right? So in lymphomas, is our area of interest in the germinal center and the maturation site of these things. So what happens to these things? We'll go now to the classification of lymphomas. So I feel you guys are very familiar with these things because it's part of third year pathology. So classification is divided into two. So one, morphology, Hodgkin's and Hodgkin's. The difference between these two is the Sternberg cells. So this one has them, this one does not. Then they can also be classified into aggressive or indolent. So high grade or low grade T1, right? So 85% of these lymphomas usually originate from mature B cells. We've seen in the previous slide here. These are 85% of them originate from from B cells. Yeah. So what are the key points? I feel like the thing about this particular subject, it usually edges a lot towards the territory of pathology, which is not your interest right now. So when you're reading these things, just make sure you don't go too much into pathology, because you won't be asked those things. All those things about the labs and I don't know how they do it under a microscope. That's not our business about right now. Our business is to find out if these people will have the disease from just not to have a disease, you have a clue of what's happening from just history, right? Because again, you guys, you won't take the bone marrow aspirate and go to the lab. The lab guys do their thing, they tell you their diagnosis, but what are you thinking about when you're taking the history? So in lymphomas, both Hodgkin and Hodgkin's, there's a male prevalence, right? So it's more likely so being a male is a risk factor. That's one of the things. In your risk factor profile, male gender, that's a risk factor, yeah? Hodgkin's lymphoma, the non-Burkitt type. Remember in Hodgkin's there's non-Burkitt and Burkitt. So there's up to a 26 times higher risk in HIV patients. So you're finding a HIV patient as seropositive patient, and they tell you they have these swellings, persistent lymphadenopathy. You start thinking about the Hodgkin's lymphoma, because there's a higher linear of it in patients who are seropositive. Yeah. Next, the other key point of take home is non-Hodgkin's lymphoma usually has a bimodal age distribution. And this is this is very high yield, because I can assure you at the end of the year you'll find a question with this multiple choice. Yeah. Question will be something, and the part choice, whatever C will be the malignancy has a bimodal age distribution. This is something you only see, not only, but this is something you mostly see in non-Hodgkin's lymphoma. Yeah. There's a bimodal age distribution, peaking during late childhood at 17 years. So the range is about, let's say, 10 to 22 years thereabout. And then the second peak to near the bimodal is around 55 years. So around 45 to 65 years. Yeah. That's where that's the second peak of this disease with ranges. So the ranges are just to be there. So bimodal age distribution is very important in non-Hodgkin's lymphoma. If you remember anything about any child, just remember is bimodal age distribution. Next, the clinical features. So clinical features of these malignancies, and you also see in leukemias, the basic principles of how these things cause diseases is proliferation and infiltration. What proliferation? Proliferation is basically increasing in number in their sites. So the bone marrow thymus. Then infiltration is now extra the knee tissue, so like outside those sites, yeah. So proliferation and infiltration. So what's the first meaning? Obviously, the things you see on examination and taking it is painless, matted, rubbery, and large swellings. Remember, you said painless are in your plastic, yeah? Matted, grouping together in your plastic. Rubbery or hard in your plastic as well. So, and large swellings in the neck. 80% of them are usually in the neck, yeah? Or the axilla, 10%. And then as much as you say these swellings in the neck and axilla, you find these textbooks these diseases don't read textbooks. You find the patient, they don't have these things in the neck and the axilla. They have swellings in the groin. And you, for some reason, you don't check the lymph nodes in the groin. And that's where the lymph nodes are. And when you go to present, you say no lymphadenopathy, and then you'll be asked, like, you check all the lymph nodes? You're like, yes. But there was lymphadenopathy in the groin, in the inguinal or whatever, and you didn't check. So always just check all lymph nodes. Contrary to what you do in what do you call it, in general exam, where you just check lymph nodes in the neck and knee. I'm sure most of you guys don't do the whole lymphatic exam, but in your onco, always check all lymph nodes. So we have like a session on this, one of these few days, on how to check lymph nodes from the head to all lymph nodes. Yeah. So these are the common lymphadenopathy in lymphomas, usually in the neck or the axilla. Next is mediastinal involvement. So about 50%, yeah, all these guys will have mediastinal involvement. So if you guys are familiar with the lymphatic system, this is like usually a high concentration. You know how the thoracic duct and all that drainage thing that happens in the chest. So you like chest involvement, mediastinal involvement in the chest is very common because of the thoracic duct. All those needs drain into the thoracic duct. So it's very common to get enlarged there. So when you have a mediastinal involvement, this means you have a swelling of lymphatics in the chest. This impedes the organs in the chest, the rest and the cardiovascular system. So you experience those symptoms, yeah? You have chest pain, you have dyspnea, cough. Simply put, those three things are enough to show mediastinal involvement. What else could you have that of a very important structure in the chest? Yes, superior vena cava syndrome, right? So in superior vena cava syndrome, what are the features that you expect now? So I put down a question and want you guys to ask. Do it as if you're doing in a chat, or you can unmute. So what are the features of SVC syndrome? So and as well as dyspnea. There's like 6 things. Just syncope. What else? Things that you will just see on examination. You don't even have to then ask the patient. Distended neck veins, collateral circulation because of your right-sided knee. Yeah. Next, what else? In the hands, you expect edemas, you expect swollen hands. So these are one of the few places where you see edema of the hands alone. Yeah. What else do you see? In the face. Let me just say that. In the face, what do you see in the face? That's in the interest of time, but that's in the face, yeah, you see swelling. And then there's something called the Pemberton maneuver, where you ask the patient to lift their hands up for a minute. And when they lift their hands up, you notice flashing of the face. Yeah? There'll be redness of the face. So that's an idea of SVC syndrome, right? Swelling in the face, edema, coughing, dyspnea, all those things. Superficial brain dilation, lymphadenopathy, Horner syndrome again. That's another thing. You expect Horner syndrome, yeah, facial swelling, and hoarseness of the voice. So that's features of SVC syndrome. Yeah. Next is marrow involvement. So this again very straightforward. If you have proliferation in the marrow, you expect a pancytopenic picture. So how do you bring on the pancytopenic picture? RBC, WBC, and platelets. So RBC, we asked about anemia symptoms. Yeah. WBCs, recurrent infections. Platelets, spontaneous bleeding, easy bruisability. Family history of, easy bruisability, bleeding gums, or what else? Spontaneous bleeding, yeah? Then infiltration also causes hepatosplenomegaly, right? So you expect especially to have a big abdomen on examination, yeah? They may tell you abdominal distension, yeah? Abdominal pain, so left or right upper quadrant pain. Jaundice in the case of hepatomegaly. Then in the case of splenomegaly, they expect a left upper quadrant pain, abdominal distension, early satiety, what else? Early satiety, anorexia. Those are some of the things you expect in hepatosplenomegaly. So you have to ask those things. Ask, just to rule out this thing, you have to ask, yeah? Neurological involvement. So, these are systemic diseases similar to TB, similar to malaria, similar to malaria, similar to hypertension, diabetes, yeah? These things are in the blood. Blood goes everywhere. So you expect these things everywhere. So don't be surprised to find neurological involvement. So what do you expect? Lymphomas, meningitis. Same as this is a type of aseptic meningitis. So it's septic and aseptic, yeah? Septic, the TBs and all that. Aseptic, affecting lymphomas, leukemias, SLE or connective tissue disease, SLE, all those things, yeah? So lymphomatous meningitis, what do you ask here? The normal things in meningitis, right? Meningitis is the headache, neck discomfort, photophobia, phonophobia, saliva, excessive lacrimation, tearing, right? Focal neurological signs. So what are focal neurological signs? So it's loss of function. So in the limb, sensation, things such as swallowing, eye movements, all those things, yeah? Then there's renal involvement. So renal involvement, what is the renal involvement? I don't know if you guys have come across something called TLS or tumor lysis syndrome. So what is tumor lysis syndrome? Everyone in the chat know what tumor lysis syndrome is. I want someone to unmute for this. I don't want to, I feel like I want to be more interactive. So is there Mark Kusao Mark? Are you in the chat? Are you around? I want to waste a lot of time here. Or Debbie, are you in the chat? Can you unmute?
I can try.
Okay, thank you. Yeah. So what do you know about TLS?
I think tumor lysis. So when there's like chemotherapy given, there's rapid cell death.
Mhm.
So then you have like excess urate and that's like released from the cells.
Yeah.
So it causes damage to the kidneys.
Yeah, that's exactly it. But then I want to correct you and I want to add some things just make it more whatever whole-rounded, yeah? So in tumor lysis syndrome, it could either be due to chemotherapy, as you said, or without chemotherapy, something called spontaneous tumor lysis syndrome, yeah? So in chemotherapy, you expect these cells are being broken down. There is lysis of the tumor cells. So in tumor cells are just normal cells in the body that manage to grow be big, similar to grow abnormally. So when you break down a normal cell, you release intracellular components such as uric acid, as you told us, because of nucleic acid, in the DNA, right? So you expect nucleic acids, you expect what else? Intracellular electrolytes. So I don't know if whoever answered this, say that. I just want to
Yeah. Yeah.
Okay, yeah. So apart from urate, what other intracellular things would you expect to leak out of the cell?
Potassium,
phosphates, LDH, so those are some of the things you'd expect. So when you have these things leaking in the DNA, you expect hyperkalemia, you expect hyperphosphatemia, you expect hyperuricemia. And with hyperphosphatemia comes hypocalcemia. So these are the 5 things that you need to know in tumor lysis syndrome. So the combination of all these things, the main thing in renal involvement is now the uric acid. Uric crystal when it goes to the kidney, all those things that happen. So renal involvement is important in malignancy because of tumor lysis syndrome. So you rule out renal involvement by asking things such as was there hematuria, flank pain, reduced urine output, things like that. Yeah. Then there's something called hypercalcemia of malignancy, also affect the kidneys. That's a lot of things to talk about. I don't want to talk about it right now, but you can just write it somewhere and read about it after the session. Yeah? Then skin involvement. So you can ask about rashes or wounds on the skin. Simple as that. Not much to say there. Then obviously there's the symptoms. Never forget to ask the symptoms. But then there's something called the Epstein fever. This is particularly important in Hodgkin's lymphoma. And then again, you won't ask this because you think, because like when you're taking the history, you know if it's Hodgkin's or Hodgkin's. Those things are done by blood guys. Just take this as a lymphoma in general. So what are you asking about the fever? Is it intermittent? So this type of fever, you expect the patient to tell you they're having fever for 1 to 2 weeks, and then they'll be febrile for another 1 to 2 weeks, then fever comes again. Yeah, intermittent fever for about a week or 2 weeks. So other the symptoms are the weight loss, unintentional weight loss, and fever, weight loss, and night sweats. So you ask about night, and this is particularly important. Night sweats, lymphocytes. Remember the activity of lymphocytes. So what do you ask about night sweats? Drenching night sweats. Are they able to? Were they like waking up in the middle of the night to change their bed sheet, or to like change their clothes, or to take off their clothes? Like they're feeling very, like night sweats are night sweats. Like they're very like sweaty, right? So that's what you ask. Basically, this is the meat of your history, the ruling in and ruling out aspect. Yeah. So we'll go to the next slide. And it is okay. So risk factors. Yeah. So you know how you usually bring a risk factor profile right before the medical contact. So that risk factors for this thing, deficiency. As we say, HIV, deficiency, Hodgkin's lymphoma, right? 26 times more prevalent. So you asked about immunodeficiency. I mean, you already have it in the body, they are HIV positive, but then if they are not, RBD positive, but then if they are not, remember this thing, if it's a risk factor, if it's not there, don't leave it out. Just say it's not there. So no patient is seronegative, right? Chemotherapy, tumor lysis syndrome, right? Autoimmunity, so rheumatoid arthritis, sarcoidosis, ionizing radiation, or chemical exposure. So this is another very important thing. In the biodata, yeah, when you check the history, yeah, when you ask this patient what do they do for work, they tell you they are farmers. When you tell you they are farmers, you start ringing bells in your head. Pesticides. Pesticides pose a risk for lymphomas, right? Right saying your biodata. So occupational history is a risk factor. Male gender, as I said, it's more prevalent in males, yeah. And family history or personal history of malignancy, obviously. Lastly, to finish this off, I want to be able to go read on staging, the 4 stages of malignancy. This is not something that you really be asked, it's just something just bonus points to know. So yeah, go read on staging of lymphomas, yeah, with involvement in the same side of diaphragm, those things. We'll see. So I think that's the end of the first slide. We'll quickly go over leukemias next. It's not a lot. It's almost pretty much the same thing. So yeah, is there any question before we move to the next set of slides? Up to this point. So I don't see any questions in the chat. Maybe you just ask them at the end if you have any questions. So this is a very short slide because it's nothing new. In fact, leukemias are much more direct than lymphomas. So we'll just go straight into it. So what are leukemias? These are neoplastic proliferation of hematopoietic cells in the bone marrow. Yeah? With accumulation in either the bone marrow itself or peripheral blood. So this eliminates we're talking about lymph nodes in the previous whatever. So here we're talking about bone marrow and blood. This is the main focus. Yeah. So that there is 4 main classifications of this thing. ALL. So these are mostly in childhood. You can see why in a few slides. AML, this could occur. In fact, I feel like most of these things, they're not textbook like diseases could occur in anyone, but like what you usually say in prevalence, it's most common in this particular age group, yeah. So as you know, you'll find ALL mostly in kids. AML, adults, mostly adults could occur at any age. CLL, this is usually very old patients. You will probably never see this in the world. CML, median age of 53, male prevalence again. So in whatever word, in 1B, yeah, the most disease is ALL. A young child, particularly male, around 12, 13 years. AML, again, these two actually are the most common ones you see in the world, or whenever when you clerk or like you go there for exams. If like you are chosen to go there on that day, yeah. CLL, you will probably never find one there. CML, very, it's there, it's not like very unique, it's not very common, but you might find a case or two. But yeah, the main unique here are acute leukemia, basically, yeah, ALL and AML. So again, we have this image, yeah. We just saw it a few minutes ago, yeah. This thing will help you differentiate if you have trouble like remembering the pages, yeah. So in the basic basic order of things, yeah, we start with ALL. So they originate from the lymphoid progenitor. So there's a lymphoid and myeloid. So lymphoid progenitor to give B cells and T cells. So when you go to the ward, I know you guys like reading the files most of the time, yeah, and they say lymphomas really affect the B cells. Most of the time when you go look at the file of these patients, you find the diagnosis written as B cell ALL. That's the most common thing you'll find. So B ALL affects the lymphocyte. Then again, the question comes, why does ALL usually affect young people or the young kids? From immunology, you guys remember in the early years of life, the immune system is still maturing. So the immune cells, right? This gives plasma cells, antibodies, all those things, natural killer cells. So in early childhood, there's proliferation of lymphatic cells. So you expect this disease to be common in younger people compared to older people since the immune system is already mature compared to AML. So in younger people, this is the priority, this green box, yeah. But in older patients, this is the priority. That's why you find this in younger patients than in older patients. So ALL is basically a disease of the lymphoblast, lymphoid progenitor. Then if it's chronic, obviously, it's like it follows chronic. It's acute and chronic. So a chronic is more, it's more, obviously it's chronic. It takes a longer time. So you affect it in this phase, yeah, in the maturation of these cells. So that's ALL and CLL. So we go to the myeloid side of things. So myeloid is your other blood cells, your blood cells, platelets, and RBCs. So in AML, this is acute myeloid. In fact, from the name, you can understand. This is acute lymphoblast. These are blasts. So acute lymphoblastic leukemia, chronic lymphocytic. These are no longer blasts. These are cells themselves. So chronic lymphocytic leukemia. This AML is acute myeloid leukemia from the myeloid progenitor. This is okay. So we've seen ALL, CLL, AML. There's one left. So the one left is CML, chronic myeloid leukemia. So chronic CML is part of this maroon box. I don't know what color this is, but this maroon box is basically myeloproliferative disorders. And some of the myeloproliferative disorders that you see are one, the myeloproliferative disorder of WBCs is CML. That's the myeloproliferative disorder of WBC. So in the chat, or not in the chat, or maybe in the chat, or someone can unmute yeah, and tell us what do you call the myeloproliferative disorder of platelets, and what do you call the myeloproliferative disorder of red cells? Those are that's how you come up with differentials, yeah. What's the myeloproliferative disorder in RBC in platelets? You say that WBC is CML, right? So what do you call them in platelets? And what do you call that disease? What do you call the diseases in red cells? Thrombocytosis, yeah, you are almost there, but like there's a certain meaning. Thrombocytosis is the phenomena, right? Because it creates obviously production of a lot of RBC. But what do you call the disease itself? The condition? Yeah, it's exactly. Some you guys are answering nicely in the chat. Essential thrombocythemia. And then in RBC, in the cells, as Angela told us, and I think okay, yeah, Angela told us it's polycythemia vera. So this is primary polycythemia. Again, I hope you guys know the difference between primary and secondary polycythemia. So this is primary polycythemia originating in the bone marrow. Yeah, secondary polycythemia is outside the bone marrow. So what patients do you expect? That's a nice thing. That's a nice thing you can talk about. Someone in the chat can unmute. Lugna, are you with us? Or Margaret? or Ian or Lumas? Mentioning a lot of names. Okay, so Margaret, you're here. Don't like can understand. Okay, yeah. So Margaret, have you heard of primary and secondary polycythemia?
Yes.
Yeah, so primary is as we just said, polycythemia in Brazil. So what can you say about secondary polycythemia?
I don't.
Like what can you tell? Yeah, what do you know about secondary polycythemia?
I know that in secondary polycythemia, it's because you have your erythropoietin levels rise because you have either hypoxia or low red blood cells, so your body reacts by producing a lot of erythropoietin, so you have a lot of red blood cells.
Yeah, exactly. So where do you expect to find? You can ask me. I think what I wanted you to say. So in secondary polycythemia, expect, as she told us, in erythropoietin deficient or erythropoietin rise. So in things such as kidney disease, when you have like renal artery stenosis, or like in fact, renal artery stenosis, you expect erythropoietin to rise because of hypoxia in the kidney, and the kidney perceives hypoxia to itself as hypoxia to the whole body. So you have EPO rising, erythropoietin being produced at secondary polycythemia. Then hypoxia again, it's commonly in the chest, in the lungs and the heart, in lungs and heart conditions. You expect the patient, because in my early rotation, the patient I got had copper and I got from Macrobion, and he asked me, like, what do you expect the hemoglobin of this patient to be and why? So in the cardiovascular ward and the chest and respiratory 7B and 7C, don't be shocked to find a patient with a HB of like 17 or 16 because of this hypoxia. You're expecting to have to be polycythemic, yeah. So yeah, I think that's we mentioned a lot of what happens here. So you can just go to the next slide. So as I told you guys in this first slide, yeah, these are the two common diseases that you find in the world, AML and ALL. Those are acute leukemia. But then again, CML, it's a chronic state. The patient does not come to you with CML. They come to you with an exacerbation in quotes of CML, which will manifest as an acute leukemia. So in actual sense, everything that you find in that word will be an acute leukemia in quotes. Although it will be CML that will be acute. So there are three phases of CML. There's the initial chronic phase, which lasts about 3 to 5 years, and the diagnosis usually occurs at this phase. They might have like a swelling in the abdomen. So that what do you call this? Of that spleen. So you might have hepatosplenomegaly, and then there's an accelerated phase. Yeah. So this usually I don't think there's a particular time frame. There is a second phase. Then the last phase, which is the important phase in this discussion, is the blast phase. Here we're talking about CML specifically. We won't talk about CLL because it's not very common, and they don't need to go deep into something you would probably never see. So the blast phase usually lasts about 3 to 6 months, and it's aggressive with rapid onset of symptoms and presents as an acute leukemia. I've written in bold acute leukemia because if you go with this idea in your head, you'll find that when you're giving a diagnosis, everything is an acute leukemia basically. These guys will come with the blast phase, which presents as an AML. In fact, one of the risk factors for AML is CML, because this thing will present as an acute leukemia. So when you're giving a diagnosis or your impression, acute, it can tell you to like shape your differential at the end, but acute leukemia is what's supposed to come out. Don't be putting CML because once again, you don't know if this thing is, you don't know the morphology of the cells. You are just taking a history and you're just going with the symptoms and thinking and like coming with at the end with what you think the patient has. So what are the clinical features? Again, proliferation and infiltration. This is the basic principle of these diseases. So what is proliferation? This is bone marrow things. So in proliferation, you expect non-specific features. So you have the lethargy, the malaise, and the symptoms, the fever, and weight loss, unintentional weight loss. Again, always unintentional weight loss. Next, we have the features of bone marrow failure. Pancytopenia, we just said, we go into RBCs, so anemia symptoms. WBC, what do you call this? Recurrent infections and platelets, spontaneous bleeding, and bleeding gums. In fact, if you're suspecting acute leukemia, the issue of bleeding gums should come out very clearly in your history. Yeah? Just about they bleed when they're brushing, they bleed when they're spontaneously. So we've covered proliferation. What is infiltration? Going into organs, such as organomegaly. Yeah, as I said, it's a systemic disease. These things are going everywhere. It's blood, basically. So organomegaly, obviously, the two important organs here are the liver and the spleen. So you affect hepatosplenomegaly, right? Don't be sure to find a patient who will have a spleen that's over 20 centimeters below the costal margin, because they are there. If you've gone to that ward, you've probably seen these things. Huh? We have a big spleen and a big liver. Yeah? Next is the bone pain. And now you know how to ask about the spleen and liver. You know the right upper colon pain jaundice, those things. Left upper colon pain, ulcer, abdominal pain, abdominal distension. So bone pain, yeah. There's infiltration in the bone pain, go into the bone because you have the bone marrow is being there's extension of the bone marrow. So, you know, there's a lot of that in the bone marrow. It grows bigger when you have bone pain, obviously, because it's like they are together, they are opposed together. So next is CNS involvement. Similar to lymphomas, I said lymphomatous meningitis. There's something called, there's again aseptic meningitis in leukemias, particularly AML. Yeah? You find the patient telling you have symptoms of meningitis, those things that by now should be at your fingertips, yeah? The headaches and all that. Then there's something called leukostasis. Leukostasis is basically a lot of the disease in the blood, making it quicker and stasis. You know, it's just not moving. So one of the risks it poses is a cerebrovascular accident, strokes. Yeah? You ask about loss of function, abnormal sensation, and loss of sensation, basically. Next is respiratory and cardiovascular involvement. Similar to lymphomas, there's a mediastinal, there could be a mediastinal mass, a thymus, or lymph nodes. Because again, these things, they could go to the organs or the lymph node. There's lymphatic involvement as well. So if you have lymphatic involvement in the mediastinal, expect a mediastinal mass impeding the organs. So you have your dyspnea, chest pain, and cough. Plus the SVC syndromes with all the whatever the things that you mentioned, the characteristics of the features of the SVC syndrome. Yeah? Next is renal infiltration. What happens in renal infiltration? Is the position of these things causing a nephrotic syndrome. I don't know if you guys have covered this part of kidney. You've gotten this part of the nephrology, where you talk about the difference between nephrotic and nephritic. So that's a quick run through. Nephrotic is basically damage to the glomerular, spleen, and inflammatory causes. Then nephritic is through inflammatory. So I mean, from the word itself, it's itic, so it's inflammatory. So here there's no inflammation. It's basically just deposition and scarring. So what are the things in nephrotic syndrome? Frothy urine, obviously periodical edema, morning facial puffiness, and hematuria. Those are things. That's how you ask nephrotic syndrome. Next, so you've done involvement in the CNS, rest, renal, bone pain, organomegaly. Yeah? Next is not very common things. Testicular swelling. You expect the patient to tell you they have swelling in their groin region. Then lastly, gamma hypertrophy and skin involvement. So something called leukemia cutis. So if you find the knowledge, like such things, you can see they have like what do you call this? Raised region on their skin. It could be, if it's like a light skin person, they appear pinkish in color. Yeah, if it's like a dark skin person, probably a different color, like purplish. Yeah, the skin involved. You can ask if there's any lumps or bumps in the skin or any rashes. Gamma hypertrophy, just swelling of the gum. Yeah, hemolysis syndrome again, like we just talked about it. Yeah, if you're still unfamiliar, you can just go read. So what are the risk factors for leukemias? Chemotherapy, hemolysis syndrome, remember that, yeah? Then exposure to radiation, to ionizing radiation. Family history, there's not much about risk factors, these things, because they just occur. Like there's nothing that can say points towards a leukemia, like a specific thing. Because again, another thing I forgot to if you guys remember something called the Philadelphia chromosome, particularly in AML, there is the translocation, yeah? So those are things that are unpredictable, like those are just things that happen out of nowhere. So the translocation of chromosome of the genes in chromosome 9 and 22, they are not wrong. So you see, that's the novel mutations that occur like out of nowhere. You can't like put a specific risk factor. So yeah, another risk factor is myeloproliferative disease. I told you a few minutes ago, CML is a risk factor for AML because like it's in the third phase, there's a chronic, there's accelerated, and there's a blast phase. In the blast phase, it presents as an acute leukemia, as an AML in fact. It's not AML, it just presents as an AML. It's a risk factor, yeah? Lastly is benzene exposure. I don't know how you can ask this, but yeah. So yeah, those are the risk factors. I think that's the end of the slide. I'll just share a history. I'll just go over one history quickly and let's see what goes on in these things. So, so for those guys who attended the first session you had, when you're talking about the hematological history, I took you through this history. So I want someone to chat. Just volunteer to read a quick 5 minutes and we'll see what goes on in these things. So anyone in the chat to volunteer? Okay, so few things running out. I'll just read it quickly. So PNM is a 46-year-old female from Kijabe, who's a retired teacher, primary school teacher. She was admitted 3 days ago, came in as a referral from Kijabe Mission Hospital. So the patient presents with a 6-month history of general body weakness, a 2-month history of abdominal swelling, and a 2-month history of swelling around the ears and the neck. The patient was last well 6 months ago when she reports to notice getting progressively weak. At first, she noticed that she would get exhausted early in the day of performing her daily activities. This progressed over a span of 3 years to her not being able to get out of bed at all. This was accompanied by dizziness, especially when she got up from a sitting position with no loss of consciousness. She experienced global headaches, global headaches for most of the day, nearly every day at gradually onset. She reports it to be throbbing, pain, non-radiating, not associated with any vomiting, diphtheria, or diarrhea. The headache was exacerbated by exertion and relieved by paracetamol and rest. She reports awareness of a loud, regular heartbeat. The patient reports having heavy menstrual bleeding over this 6-month course, which resulted in her receiving 8 blood transfusions. She has been on follow-up with a gynecologist, and after numerous tests, no gynecological pathology has been detected. She has noticed bleeding. She has not noticed bleeding. Actually, that's what I want to put that. She has not noticed any bleeding from any other side, but she thought that whenever she gets small cut, they tend to bleed for prolonged periods. She has had a sore throat for the past 7 weeks and reports being treated for a UTI 4 times in the past 6 months. The patient reports noticing a swelling in her left upper abdomen 2 months ago that has progressed over time to most of her abdomen. She reports it to be hard and painless. She reports that as the mask grew, she had reduced appetite, increased bloating, and nausea. The patient also reports noticing firm masses around her ears and on both sides of her neck. Those in the tonsillar region were painful, while all the rest were painless. Yeah, I feel I don't. Sorry. The last part of the history. The patient reports experiencing hardness of body, night sweats, and unintentional weight loss of 27 kg over the 6-month period. There is no history of contact with someone infected with TB. She is IgG negative, last tested 2 weeks ago. She has never been treated for malignancy before. With a family history of breast cancer, which affected her mother, and no other malignancy. She does not smoke. She is not on any chronic medications. She has no exposure to radiation via CT, scans, or X-rays. She has never worked at a chemical plant or with paints. She has no known comorbid conditions. She does not drink alcohol or partake in recreational drugs. At Kijabe Mission Hospital, she received a blood transfusion prior to the referral. Upon arrival at KNH, she had a second blood transfusion and an abdominal x-ray was done yesterday, for which she awaits results. She is sent for an abdominal ultrasound later in the day. She's still very weak and reports no significant change in her health status since admission. So I won't go over these other things because they're not very relevant to our case today. So that's the sample history of how you are whatever supposed to look like, how you are a hematological history. And in this patient, you can see there is all these things that you talked about, not all, like, not all these things that you talked about. You know, there's the B symptoms. You have there's blood, what is this? You're seeing symptoms of RBC, RBC loss, you're seeing platelets, platelets problems. You're seeing lymphadenopathy, you're seeing masses in the abdomen, right? So you're seeing head, you're seeing what is it? Weakness, general body weakness, yeah. So this is how you would basically bring out the symptoms of this. Okay, before you even go further, this is how you bring out the symptoms of a leukemia. So this when I was taking, I wasn't the one taking the history, but whoever took this history, yeah, it was one of my friends who I borrowed the history from. Yeah, this when you're doing this history, at some point you start suspecting something. So when you most of the time a patient who has leukemia will be the history will kind of be direct. That's a good thing about this thing. It will be direct. So when you start thinking about these things, how do you come up with a whatever, what do you call this, an impression? Because you give an impression at the end of this thing. So the impression that you give, once again, I repeat, you are not in the lab. You're not in the lab. You're not in the pathology thing. You don't do the FNA. You might do FNA, but not as a student, in the future years. Yeah. When you take the history, you suspect a leukemia. Let's say you find out at like a 38-year-old. Yeah. So at this point, you're suspecting maybe an acute myeloid leukemia and an AML. Most likely to be an AML, but then you won't go to the impression and say, like when the doctor asks you what you think the diagnosis is, you're going to say acute myeloid leukemia. Because one, they'll say you read the file, you want to study the file. And number two, you don't know the morphology of these things because you haven't done that bone marrow aspirate. Remember, when you go to exam, it's like don't go with the idea that you've seen this patient before, even if you have. When you're taking a history, this is the first time you're meeting the patient. This is the most, you can have the most mini diagnosis, the most wide diagnosis you can give. So how do you frame a diagnosis in such a patient? Or in a patient that's suspecting has a leukemia? Remember, at the start of that, or the leukemia or whatever slide you said, the main things we see is AML, ALL, and CML presenting as an AML. So the umbrella term here is an acute leukemia. But then, how you come up with the differential? You're going to say acute leukemia. You're going to say bone marrow failure secondary to an acute leukemia. Bone marrow failure secondary to an acute leukemia, because you have the symptoms of bone marrow failure and you have the symptoms of an acute leukemia. This rapidly, the patient has lost 27 kg over the past 6 months. She has lymphadenopathy. She has all these things. These are signs of an acute infection. So how you make the differential? Your diagnosis: bone marrow failure secondary to acute leukemia. And that's clear. Bone marrow failure. That's those exact ones that are the ones you're going to give. So then when you're giving the differential, now you can now go into the AMLs and the if you're thinking polycythemia, if you're thinking essential thrombocythemia, if you're thinking CML, that's where you give now those technical things in the differentials, because it's one of the things that I think about in thinking history. But then the depression, never give a very straightforward depression, particularly in leukemia, because that's you have to that you are studying the file, or you are just guessing your own things. Because what if the patient doesn't have an AML, what if the patient has an AML? Remember, these things are not set in stone. You might get at this age someone getting a disease that affects children primarily, right? So it shouldn't it's not set in stone. Just give a diagnosis or the different impression as bone marrow failure secondary to acute leukemia. So up to this point, we've covered lymphadenopathy, malignant lymphomas, and leukemias. Does anyone have a question? I'm going to stop the screen sharing. So yeah. So does anyone have a question?